Hello, everyone. Thank you for joining today's Web Interface Support webinar. These webinars are for accountable care organizations and groups that are reporting data for the quality performance category at the Quality Payment Program through the CMS web interface for the 2017 performance period. CMS will highlight important information and updates about reporting quality data and provide ACOs and groups with the opportunity to ask their questions. Please note that these calls will only focus on reporting data for the quality performance category. We will not cover reporting data for the other performance categories during these calls. Now, I will turn the call over to Aruna Jasti from the Center for Medicare and Medicaid Innovation at CMS. Please go ahead.
Thank you, Stephanie. Welcome, everyone, and thank you for joining our support call on quality reporting through the CMS web interface for the 2017 performance year. I am Aruna Jasti, and I'm with the Next Generation ACO model from the CMS Innovation Center. Also joining me on this call today are other CMS web interface experts who will share helpful information and answer your questions during our Q&A session after today's presentation. Next slide, please. This slide is a disclaimer and is a reminder that information on these slides are current at this time of this support call. We encourage everyone to use and reference the source documents that are cited and provided throughout the presentation. Announcements or updates will be shared on these support calls or your program-specific communication methods, so we urge you to please stay tuned to any communications from the Quality Payment Program, Shared Savings Program, and the Next Generation ACO model for updates. Next slide, please. Some quick reminders. The 8-week CMS web interface submission window opened on Monday, January 22nd, and will close Friday, March 16th at 8 p.m. Eastern Daylight Time. We want to remind everyone that there is no submit data to CMS option in the web interface this year. We will automatically receive data that you have entered into the web interface at the closing of the reporting period. Again, whatever data you have entered into the web interface as of 8 p.m. Eastern Daylight Time on March 16th is automatically submitted to CMS. If you are experiencing issues trying to access the CMS web interface, please contact the QPP Service Center for support. Also, an important reminder, our next weekly support call is on March 14th at 1 p.m. Eastern Time. This is the last support call before the CMS web interface closes on March 16th. Next slide, please. We have a few announcements for you today. As a CMS web interface user, you may have been recently contacted by the Quality Payment Program to address and resolve an issue with the CMS web interface beneficiary sample files that you may have downloaded from the CMS web interface. If a Quality Payment Program Service Center representative was able to reach you, they had you access previously downloaded files and resave them to ensure the files were fixed. If you were not available, the Quality Payment Program representative left a voicemail callback number and ticket number you could use to call the QPP and complete the process. In order to reduce any concerns from CMS web interface users that these phone calls may be phishing scams, we wanted to assure you of the authenticity of these calls. If you received a message and have not yet been in contact with a QPP program representative, we urge you to contact us via the callback number and ticket information left in this voicemail. Please note that this issue with the beneficiary sample download does not affect your ability to report data in the CMS web interface. CMS encourages ACOs to continue quality reporting. If you no longer have the information left via voicemail, or if you have questions regarding the CMS web interface or the Quality Payment Program, please contact the Quality Payment Program. And a quick reminder, the webinar materials from the previous CMS web interface support calls are now available on the QPP webinar and events page. Next slide, please. I'll now turn the presentation over to the next speaker, Katie Moore.
Thank you. Next slide, please. So we're just going to quickly review the CMS approved reasons. Just a reminder that the CMS approved reasons are reserved for cases that are truly unique. So once we have reviewed, if it's determined that the request is not unique or an unusual circumstance, it's likely the request will be denied. Your CMS approved reason request should be submitted as soon as possible. The longer you wait to submit a request, the higher the chances are it will not be reviewed before submission closes. In order to request a CMS approved reason, you should submit an email to the Quality Payment Program Service Center and include the patient rank, the measure, and a detailed reason for your request. Please only submit one request for each unique scenario, and remember to never include any PII or PHI. In some cases, the Service Center may ask you for more information, so please be prepared to respond to any follow-up inquiries. Next slide, please. And now I will go ahead and hand things over to Ralph Troutwine. Thank you.
Thank you very much. We're going to provide you some helpful information at this point based off of some of the help desk tickets we received and the observations we have from submissions. Next slide. In the screens you're about to see, I'm reminding you that there is no protected health information, PHI, or personally identifiable information, PII, present. Everything you're about to see is all test data and test organizations. There is no real organizations or real beneficiaries in these slides. Next slide. So some Excel file guidance. One of the things we've observed, and this is not everybody, this is just a few users, but I'm warning you against doing this, and that's that some folks are copying the patient list, the beneficiary tab, to multiple tabs in the spreadsheet. I don't know if they're doing it for version control purposes or why they're doing that, but we're seeing some bloated Excel files where they've copied their beneficiary list multiple times to additional tabs in the Excel file. We only process the first worksheet, and any additional worksheets are not processed in the file, and it slows down your file transfer. So we recommend that you not use that as a way to store supplemental beneficiary information or version control your information. You can at any time download with data a copy of everything that the system has accepted to date and keep that as a separate Excel template. But please do not copy multiple worksheets within your Excel file. Next slide. Another thing that we've observed, and this is only a few people, and we're not even sure how they managed to do this, but they've extended the Excel formatting to the maximum number of rows that Excel accepts, which is 1,048,576 rows. By default, the spreadsheet only has a little over 8,000 rows formatted, which covers everybody's Benny sample capabilities. If you've extended the row count in Excel to the maximum 1,048,576 rows, the system has to go through each one of those rows looking for data and can slow down your Excel processing. So please don't add extra blank rows at the end of your spreadsheet when you're submitting it. Next slide, please. So we've had a number of help desk tickets around skipping large numbers of beneficiaries. And I'm using MH1 as an example because that seems to be a measure where a significant number of skips occur. In this example, I'm showing you how the system reacts if you skipped every beneficiary in MH1. In this example, notice that you've reported on every beneficiary, but the minimum still indicates that it's not met, and the measure count is still not incrementing. So you skipped every beneficiary in the measure, but the measure count will not increase, and the minimum met indicator does not change. Next slide. So here's an example where they reported on 18 beneficiaries and skipped all the rest. Until you reach 20 beneficiaries that have actual real results that aren't skipped, then the measure increment count does not increment. It stays for example, in this case, 0 out of 14 measures are complete. So I have submitted 18 beneficiaries, and it now flipped to met the minimum because I've skipped all the rest. So the met minimum flag flipped because I reported on all the beneficiaries that I had to report, but the measure did not increment, so it remains at 0 out of 14. Next slide. So in this example, we finally reached 20 beneficiaries that have been reported on for MH1. And here you see the minimum met flag is flipped. It shows you've met the minimum, and the measure count incremented by 1. So once you've reached that number of 20 beneficiaries that you've actually reported data on and not skipped, the flag will flip from 0 to 1 as a complete measure when all the rest of the beneficiaries have been skipped. If you're not skipping beneficiaries, you still need to meet the minimum requirement for reporting before that flag will increment. Next slide. So this is specific to groups who see the performance points. In measures with benchmarks, and here you see this particular measure has a benchmark, you will receive performance points. And here you can see that this measure's met the minimum reporting requirement, and in this particular case, they've gotten 7 performance points for this particular measure. Next slide. For groups who see performance points, measures without benchmarks will not receive performance points in the interface. So here in this example, Prev 13 does not have a benchmark, and therefore the performance points are not shown. We have gotten quite a few help desk tickets around this issue where for measures without benchmarks, they've met the minimum, they've reported all their data, but don't see performance points. That is expected behavior in the application. Again, this is only for groups who see performance points. Next slide. Okay, I'm going to hand it over to Jessica now.
Great. Thank you, Ralph. So the next section, we'll quickly go through resources and where to go for help, and then we'll jump into our Q&A session. Next slide. On slide 17, you'll see the list of CMS resources that are available on the QPP Help and Support website and also on the QPP Resource Library. At the bottom of the page is a link to the QPP Webinar and Events page, and a friendly reminder that is where the questions and answers document and the webinars and transcripts materials, that's where they're also posted, is on the QPP webinar and events page. Next slide. On slide 18, you'll see the list of the CMS Web Interface instructional videos. If you're having some trouble or if you just want to know what next steps are in the web interface, please take a look at these videos. They provide a nice walkthrough of the system and provide step-by-step instructions on what to expect as you report. Next slide. Slide 19 are resources for the ACOs. Starting with Shared Savings Program ACOs, please reference your website and the program guidelines, guidance and specifications. Also, please keep an eye out for the ACO Spotlight newsletter. That newsletter does provide useful information and important announcements regarding website reporting. And same for next generation ACOs. Please reference materials on your website and the Connect site, and keep an eye out for that weekly newsletter for important announcements. Next slide. Slide 20 lists our contact information for the QPP Service Center if you have any questions. And again, if you want to submit a request for CMS approved reason, please contact QPP Service Center at qpp@cms.hhs.gov. And I believe that's it for our resource slides. Next slide. I will hand it over for the Q&A session. Thank you.
We are now going to start the Q&A portion of the webinar. You can ask questions via chat or phone. To ask a question via phone, dial 1-866-452-7887. If prompted, please provide the conference ID number 7208-7470. So this first question comes from a Care2 ACO organization with over 25 providers, and they're asking, would an encounter for a fall meet the intent of the measure, either by our provider or in the ER or for imaging? And they say also if the ER consistently does a fall risk assessment in order to tell if the patient needs fall risk band, rails up on the bed, etc., would this count?
Hi, this is Jessica from the PIMS team. So any medical record documentation that any medical record documentation that indicates that the patient had a fall would count as a screening. Therefore, in this instance, it would count as long as you have that medical record documentation. If the documents just indicate the patient was there because of a fall, that doesn't mean they met the intent of the measure. There has to be that documentation stating the patient's fall history or that there's an injury due to a fall or a gait assessment. Thank you.
Thank you. This next question is about IVD-2. If we find an anticoagulant for IVD-2, are we supposed to still look for an active diagnosis of IVD, or can we stop since the patient will be excluded at this point?
Hi, this is Angie from the PIMS Measures team. That is correct. You would exclude the patient from the denominator because they had documentation of use of the anticoagulant medication during the measurement year. And the diagnosis, as I'm looking at the spec, I think that you are verifying that kind of all at once on the template, but I'd have to have Ralph confirm that. So the answer would be that it is a denominator exclusion. Sorry.
Thank you. This next question is, for Prep 7, what dates are included when looking at visits?
Hi, this is Angie again from PIMS. For 2017 reporting, the sampling process identifies the patients, the eligible patients for the sample, and verifies that they have at least 2 visits or 1 preventative visit during the measurement year. They also verified that the patient had a visit between October and March. That is a requirement for the measure, but you are not responsible for confirming that. So you would only need to determine if the patient received or reported previous receipts of the influenza immunization between August 1st, 2017 and March 31st, 2017. And
she hates
that is already
to correct you, but it is August 1st, 2016.
I'm sorry. Thank you so much. I don't know why that always just
didn't want to confuse someone.
And here we are in 2018. I apologize. That's correct. So you're looking for the immunization between August 1st, 2016 and March 31st, 2017. Thank you.
Thank you. This next question is for Prev 13 statin. If the patient is a diabetic and the LDL is less than 70 and not on a statin spec that says they can be an exception, how is this recorded in the web interface? When the answer for the question is diabetes LDL 70, 189, you answer no and can't get to the statin question to enter medical reason exception.
Hi, this is Ngozi with the PIMS team. So when you're looking at the Excel document, you document a denominator exclusion in column CP and column CR of the Excel document. All exclusions should be captured in these columns. Denominator exceptions will be captured in column CW, which is titled, was the patient taking or prescribed statin therapy between January 1st and December 31st, 2017. It's a conditional field that opens when you say yes. If you say no, then it really doesn't open the next question, which is asking if the patient was on statins, because it's not necessary. Thank you.
Thank you. And Stephanie, I think we can take a question from the phone at this time.
Our first question is from Jason Shropshire.
Hi, can you hear me?
Go ahead.
Hello?
Yes.
Yes, I have a couple questions. So my first question is, can you please confirm, because I can't find anything on the website, what are the total possible points for groups and ACOs?
Hi, this is Robbie. I come from CMS. So I don't believe we have anyone on the line for MIPS scoring. So I don't think, I know for ACOs, and I can pull up, there's a quality category scoring guide that's available on the Quality Payment Program 2017 resource library that walks through for ACOs how the quality category will be scored under MIPS. And I apologize. If you would like to send that to the Quality Payment Program Service Center, we'll make sure that someone on the scoring side can respond to that.
Hey, this is Tim. Can you hear me?
Make sure that someone from the scoring is there at the next Wednesday. That would be very beneficial. I'm sure other people are interested.
Yeah.
Hey, Robbie, this is Tim. Can you hear me?
Oh, Tim is on. Great. Thank you. Yes.
Yeah. So if you'll just go to Google and type in MIPS Quality Performance Category Scoring for MSSP and NextGen ACOs, it'll take you to the 2017 Resource Library page. And you select that file and it pulls up a PDF document which lays out the performance category scoring for MSSP and the web interface groups. It's a side-by-side. As you scroll all the way down to the third page, it shows you your totals, and it does a side-by-side comparison on which ACO measure and measure title are applicable. I'm trying to figure out how to send that to the group. We'll figure out how to do that, but and post that with the notes for today. But that should answer your question. Thanks so much.
Okay, our next question is, we are experiencing an issue with the web interface upload not recognizing the CMS ticket numbers for the ESRD patients. Is this a known issue?
This is Rabia. If you're a shared savings program ACO with ticket numbers associated with the CEC skip, the CMS approved skip request, can you please escalate your tickets with our regional coordinators? That'll help us identify and be sure that we can pull those tickets to address them. Or Olivia, I don't know if you want to add anything else.
No, I mean the ticket numbers we provide are the ones from the QPP service center. So yeah, if we could escalate those to the web interface developer, that would be great.
Yep.
Thank you. This next question is for Prep 6. Does the format of the date of the colonoscopy matter? Is the year acceptable or the month and year?
Hi, this is Jessica from the PIMS team. There is no specific requirement for the format of the date, so any type of date would be acceptable, but please note on page 8 of the measure specification, if the patient is reporting their screening, then the date must be the year or more. If there's a day and month, that would be great, but for patient reported, at least there has to be the year. Thank you.
Thank you. This next question is, if a patient self-reports PREV 8, what are the guidelines for passing them? I know if it is before 2015, the guidelines are slightly different.
Hi, this is Ngozi with the PIMS team. So if the patient reported for the PREV 8 measure, what's required is the date, meaning the year, and the type of vaccine. However, if the patient reported prior to 2015, documentation indicating receipt of the vaccine and the date and year will be sufficient. If they reported in 2015, 2016, 2017, documentation indicating the year of the vaccine and confirmation of the type is required. Thank you.
Thank you. This next question is, if a member has been attributed to our ACO due to specialist, but the primary care provider is not part of the ACO, what are we to do to complete the measures?
Hi, this is Sarah Growlert from ACO PAC. I'll take a stab at this one. So there's a couple ways that a beneficiary makes it into the sample after they're assigned or aligned to the ACO or group. And the first thing that we look for is that that beneficiary has 2 visits where primary care services were provided during the measurement year. So that's the first step that we're looking at. It's not necessarily with a primary care provider. And how they're selected into a specific sample also isn't necessarily related to whether or not that visit occurred with a primary care provider. So the expectation would be that you would continue to report on that beneficiary.
Thank you. And Stephanie, I think we can take a question from the phone.
Our next question is from Andy Renandi.
Hello. My question is about Care 1. When we were uploading Care 1 through an Excel file, we received an error message that said the provider was not found or to be associated with our organization. I confirmed it, and that provider is associated with our organization, and he has had more than 1,500 Medicare billed encounters in 2017, so I'm not sure why that error is showing up. Also, I want to know what we can do to rectify this.
So we would have to take a look at the Excel upload that you performed. If you could open a ticket with the details, including your organization and which beneficiary you're having problems with, we can take a look at that Excel file and help you with resolving that issue.
Okay. I've already opened a ticket, but I just wanted to ask this question, and just in case. I have one more question also.
One other thing to add about that is make sure that they're in managed providers. If you go under managed groups within the web interface and click on managed providers, and make sure that they're in that list. Okay.
They are in that list. And the NPI numbers match. The last name does not match exactly, but the first name and the NPI numbers match exactly.
And so we are doing a check on first name and last name, so they would need to match within the managed providers and in the Excel spreadsheet. So that's what we do, the name. The check is on the name in that case.
Okay. Okay. My other question was regarding the mental health issue that we just discussed. For us, we also skipped a huge number of the 616 patients, but our consecutively completed ones it's exactly at 19. So according to the previous, what you guys said previously in the webinar, we need to reach 20 before it will count towards our total measures complete. Now, what actions should I take right now to ensure that happens? Because we've completed everything and we can get one more.
This is Robbie. I'll jump in. I'll start, and then Ralph, please jump in. And I apologize. Are you a group practice, or are you in
group practice?
Yeah, you're group practice. Okay.
Yeah.
So to help clarify, so the complete count, those totals that show up on that about measures completed, is very specific to MIPS scoring purposes. So for MIPS scoring, you need to have at least 20 cases in your denominator for that measure to be eligible for MIPS scoring. So if it's less than 20, that's why it's not appearing on that count in the upper right corner for the complete count. However, you still need to complete the 248 consecutive complete reporting. And if you have a denominator after you've completed all of your reporting and and it's still less than 20, I think ultimately that's okay. It's just it's not going to show up on that complete count list and will not be included as a part of your MIPS score for quality for that. So that measure may not be included then in that score. And so I would recommend confirming, that you've met the minimum reporting requirement on the measure, I think like the sheet.
Got it. Okay, yeah, I think we've met the minimum.
And I think in your case,
your point.
Right.
Right, and I think in your case, you've actually reported on every beneficiary. It's just that your reporting was such that a majority of them fell into the skipped categorization. So you've reported on every beneficiary that you can. You just your reporting ended up skipping a lot of beneficiaries.
That's correct, yeah. Okay, thank you.
Yeah. Right. This next question is, if a patient has a PHQ-9, but the clinician does not indicate whether the score was positive or negative, how do I answer the question of, was the screen positive for depression between January 1st and December 31st, 2017?
Hi, this is Jessica from the PIMS team. So you aren't able to answer it, so you would need to select no. The rationale is that the clinician provides their results, their interpretation of the screening, so that the rest of the care team is crystal clear understanding that whether or not that patient has depression. So for that, you would need to select no. Thank you.
Thank you. This next question is, for PREP 6, is a patient-reported colonoscopy with results acceptable?
This is Jessica from the MIPS team. Yes, patient-reported colonoscopy is acceptable. Please make sure that you have medical record documentation that indicates the date of the colonoscopy, the type of the test, obviously a colonoscopy, and also the results and findings from that test. Thank you.
Thank you. For this next question, this person says that Care 1 CPT codes 99496 and 99495, transitional care management visits, are not listed in the PREV coding document as an acceptable encounter code for that metric. Will these still count as a visit within 30 days of discharge?
This is Jessica from the PIMS Measures team. And yes, transitional care management visits will count when they are performed in outpatient settings. if the TCM was conducted during an outpatient within 30 days, then it definitely counts. So do make sure that it's within those 30 days. Thank you.
Thank you. This next question is, why are there 750 statin patients in our sample?
Hi, this is Sarah from ACOPAC. As you may recall, this was a new measure last year, performance year 2016, and it's a bit of a complicated measure with 3 different risk categories, and the decision was made to provide a larger sample for this measure in anticipation of a high skip rate.
Thank you. And Stephanie, we can take a question from the phone.
Our next question is from Jody Quattrochi. Jody, please go ahead.
Hello?
Go ahead.
Oh, shoot. Hello? Hello? I'm sorry, hello?
Jody, we can hear you. Jody, can you hear us?
It looks like she may have lost her line. Would you like to go to the next question in queue?
Yes, please, Stephanie.
The next question in queue is Rebecca Venhoopen.
Hi, thank you for taking my call. I noticed that the skip thresholds are a little higher than in the past because the skip reasons are lumped into one bucket, whereas in the past our report showed each skip reason segregated from the other. For example, not qualified for sample had a separate skip threshold percentage compared to medical record not found. So I'd like to know, how will CMS view skip thresholds going forward, considering that skip thresholds are used as flags for audit, and we may have skips due to CEC beneficiaries that shouldn't have been attributed, or we had beneficiaries that died and are required to be excluded.
This is Rabia, and speaking for the Shared Savings Program. Right, so the data that we'll be receiving for our quality measures validation audit, we will break down the types of skips and take a look at anomalies based on specific skip rates, so like medical record not found, like you noted. Moving forward, I think that's great feedback for us to hear. We're planning to do a lessons learned as well with this reporting cycle, and we'll take that as feedback for improvements for next year, I think, as well, because that's helpful to note that you guys also want the breakdown of each skip rate, and I completely understand.
Yeah, it is helpful. So, but thank you for answering that and understanding, where where the ACO population is coming from in that regard. So, thank you very much.
Absolutely, thank you.
All right, our next question is, how do we clear previously entered data through the web interface? For example, change the content to null.
Ralph, did you want to address that question?
This is Rabia. Could you repeat the question real quick? Sorry.
Yes. So the question is, how do we clear previously entered data through the web interface? For example, change the content to null.
Okay. So there's one way to do that, and that's through an Excel upload. So if you find the piece of data that you want to remove altogether, to null it out, enter NA in that cell in the spreadsheet and upload it, and it will remove your data entry for that particular answer or particular piece of data.
Thank you. This next question is, if a BMI is obtained and abnormal, is it acceptable for the follow-up plan to be completed on a separate date as long as it is within the previous 6 months? Would a handout with the after-visit summary on appropriate diet or exercise be sufficient to count as a follow-up plan?
Hi, this is Angie from the PIMS team. As for the BMI completed on a separate date, yes, as long as the recommendation for the diet or exercise was as a result of the abnormal BMI or of an abnormal BMI at the visit or in the 6 months prior, and it was discussed with the patient and documented in the medical record, that would count. You can find the definition on page 6 of the measure specs of follow-up plan. And you can also find some follow-up plan guidance with an example of what needs to be documented in the medical record.
And this is Deb from the PIMS team. I just want to clarify that you can use a follow-up plan from a previous visit, but you can't use a follow-up plan that is not linked to an abnormal BMI within that 6-month period. So you have to have both the abnormal BMI and a follow-up plan linked. And the rest of what Angie shared is absolutely correct. You can certainly hand out a document that provides the patient with some information on what you're recommending as a follow-up to an abnormal BMI, but you would want to have that information documented in your medical records in the event of an audit.
Great, thank you. This next question is, for the IBD measure, if you have a patient that was on aspirin at the beginning of the measurement period, but was on an excluded medication later in the year, should this be marked as confirmed, yes, on aspirin, or excluded based on the excluded medication?
Hi, this is Angie with PIMS. That would be a denominator exclusion for patients who had documentation of use of an anticoagulant during the measurement year. Thank you.
Thank you. For this next question, this person says, our patient sample contains patients who belong to a physician who has retired, and so we do not have access to the patient's charts. In this situation, do we have to indicate that the physician has retired, or should we just select medical record not found?
This is Olivia from ACOPAC. I can take a quick stab at that. I'll just remind you that patients and beneficiaries are assigned to your ACO as a whole, not to particular providers within the ACO. And we do expect ACOs to make a concerted effort, to obtain the information they need for quality reporting. That said, if you're truly unable to access the patient's medical records, then it would be appropriate to select medical record not found.
Thank you. And Stephanie, I think we can take a question from the phone.
Our next question is from Jody.
Oh, am I here again? Hello?
You may go ahead with your question, Jody.
How do I get on?
Are you on speaker?
Hello? Hello?
Jody, go ahead with your question.
Okay, so for the MH1, our question, because we have less than 20, we went through all the beneficiaries and skipped all 119 beneficiaries. So we had to skip all of them because we don't do the PHQ-9 here. So that's going to show up as incomplete, and it doesn't change. I understand it won't change the number of measures, but the measure is remaining incomplete. Don't all measures have to be submitted to have that you successfully participated in the web interface?
Yes, this is Rabia, and Ralph, jump in again for this. But so the complete count that shows up on that screen, and I'm wondering if we can go back a couple of slides to show what slide number that is. I wonder if we can go back a couple of slides so we can get to the screen that had the complete count in the upper right corner. But essentially, the complete count indicates to you which measures meet the MIPS criteria for scoring. So those are the measures that will be eligible for scoring. So they have to have a denominator of at least 20 bennies or cases.
Yeah, one more.
add one more.
There you go.
Slide 13. So yes, here we are. Sorry, slide 13. So yes, so in the upper right where it says 1/14, that's in relation to the measures that are eligible for MIPS scoring. So if you, like I said, if you have less than 20 cases, so for your instance, you've skipped all of the beneficiaries in your sample, so you've completed that consecutive reporting requirement, but because you don't use the PHQ-9, you've skipped everyone, you have a denominator of 0. So they're not going to show up in that upper right complete count because it's not meeting the criteria for MIPS scoring. So it won't be in your MIPS score. However, you should check your measure progress like it showed on the screen to ensure that it says minimum met. So to ensure that you've met the complete reporting requirements to meet the criteria for complete reporting.
Rabia, I think she's referring to maybe what's on an earlier slide. I don't know if it's the one directly before this one or...
Because it still shows that it's incomplete, that the measure itself is incomplete.
11.
And we were under the impression that for web interface reporting that all measures had to be completed.
Yes,
right.
I mean,
because it still says minimum not met.
So
on the slide that we're on, in this example, the user has skipped every single beneficiary in the measure. And so if in that case the application indicates that the minimum is not met for this measure because there are no beneficiaries that have data reported against them, and the measure count does not increment. As soon as you start to have one or more beneficiaries that you reported that are not in the skip category, on the next slide,
there's no more beneficiaries. Right, there's no more beneficiaries showing up.
And even if there were, we wouldn't ever get
yeah.
Right. So this is how the application behaves, and we're trying to show you how it works. So if you have 1 to 19 beneficiaries that you had data for that you could report on, and they didn't count as skipped, then it will show minimum met with all the rest of them skipped, and it will not increment the measure count.
Right.
But what if all 119 are skipped? Can you hear me?
Okay, because when we go to pull the report, it still shows that it's incomplete, and I think that's what's throwing us off.
Because we have none.
So this is Rabia. I think it would be best, obviously, to always download your reports and take screenshots. And I think the other piece of this is just as long as you've completed reporting on your entire sample, then you have met that requirement. And I understand the system is not apparently recognizing that once you've skipped everyone, it doesn't recognize it as being complete. But if you've skipped everyone and you reported completely on that measure, please keep record of that, I would say also, but we will receive that data as is and accept it. Yeah.
Okay, because that's what we were concerned about. Is this, exactly, the system is not recognizing that.
Absolutely, I completely understand. We will.
So should we go ahead?
Go ahead. Oh no,
should
please
we
go
send
ahead.
a screenshot? Should we send a screenshot in?
No, I think for your record, so long as you completed reporting, in general, I think I recommend for everyone to, as you're reporting, download your reports and keep those screenshots for your own purposes and records. There is a report that is generated right after the deadline at 8 p.m. on March 16th that will confirm that we've received all of the completed data. So that is definitely another form of confirmation for you. But yes, so essentially the system, because you've skipped everyone, is not recognized as complete, but you've reported on each of your beneficiaries, and we understand.
Correct.
Yes.
Okay, will do. Thank you.
All right, and before we move on to the next question, I think Jessica wants to jump in to clarify some info on Prev 12.
Thank you. This is Jessica. I just wanted to clarify a previous response I gave may not have been very clear. So regarding the question for Prev 12, if the clinician did not indicate whether the score was positive or negative for depression, then how do they answer the question, was the screen tool positive for depression during the measurement period? So when I am thinking through this, I'm looking at page 14 of the measure spec. I'm looking at the measure flow for Prev 12. At the top of the flow, there's that question, patient was screened for depression using a standardized age-appropriate tool. Yes, if they were screened based on this inquiry. The next question, patient had a positive screen for depression during the measurement period. That's where you would select no, and that pulls you over to the performance met. The patient will be pulled into the numerator because you're not able to indicate whether or not it was positive. If it is positive, then the flow, you continue on to the follow-up questions about the follow-up plan. But in this instance, if the patient does not have medical record documentation of a positive or negative score, then unfortunately you can't go much further in Prev 12. So you would select no to that question. Thank you.
Thank you. This next question is, after an ACO submits data, will the associated TINs be able to see the data on QPP if they log in with their own EIDM accounts?
I apologize. Could you repeat that one?
Yes. So after an ACO submits data, will the associated TINs be able to see the data on QPP if they log in with their own EIDM accounts?
And Tim, please jump in here. So our understanding is, so once the ACO completes reporting, the ACO reported data on the back end is going to be used to calculate the quality category for MIPS eligible clinicians within each ACO who are subject to it. The MIPS scores will not be available right after the submission window closes. There will be a notification from the quality payment program of when eligible clinicians can log in and locate their MIPS quality category and other scores.
Yeah, this is Tim. That's correct, and they'll also be available with the performance feedback in July.
Great. Thank you both. And it looks like we have time for one last question. So this question is, what types of groups are able to see performance points?
So all groups can see performance points when they've met the minimum of 20 beneficiaries or more for the met the minimum reporting for the measure. So if you're in a group, not an ACO, then for the measures that you have that have benchmarks, once you've met your minimum reporting requirement, you will see the performance points.
Great, thank you. And that concludes our Q&A and the webinar for the day. So thank you all for joining.
Thank you. This concludes today's conference. You may now disconnect.